following, I would like to demonstrate a diaphragm-detonating thoracic mobilization technique and describe its effect on posture, breathing, the autonomic nervous system and the accessory respiratory muscles. At first, the case description. I used the technique on a nearly 40-year-old female patient with chronic tension in the shoulder and neck area, as well as in the area of the scalene muscles and the sternocleidomastoid muscles. The patient was unable to breathe into the abdomen. Therefore, I assumed that the diaphragm is permanently tense and needs to be stretched. There was also a general decrease in performance due to a known HPU, which is a genetic metabolic disorder that occurs mainly in women, as well as poor posture with a backward sloping of the trunk and chin protraction without evidence of Scheuermann's disease. There was also no evidence for significant limitations in spinal mobility, with one exception. During the manual medical examination, a painful dysfunction or misalignment in the middle cervical spine at C4 is observed. This is the segment of the phrenic nerve which innervates the diaphragm. The treatment is carried out with the patient in a relaxed supine position. Let's come to the technique. The first treatment sequence. Here the anterior rib arches are pulled laterally and cranially at an angle of about 45 degrees for 20 breaths. The practitioner holds the rib arches with his long fingers in the maximally possible spread position. Limiting factors here are, on the one hand, the strength of the practitioner and/or significant discomfort on the part of the patient. This sequence is followed by a break of 3 to 5 minutes. This technique is then used again a second time for 20 breaths and again followed by another 3 to 5 minutes break. Finally, chest mobilization is performed in time with breathing. In this process, the chest is spread during each inhalation phase and compressed in a caudal medial direction during each exhalation phase for a further 20 breaths as described above. This now requires the practitioner to reposition their hands in time with each single breath. So what was the effect of this treatment? Subjectively, there was a general relief in breathing, as well as a significant general relaxation of the patient. Furthermore, the patient reported hand and foot perspiration during the treatment. The patient found the first treatment sequence quite uncomfortable and sometimes painful. This unpleasant experience decreased with each single sequence. Objectively, abdominal breathing was fully restored after the 3 treatment sequences. The tension in the area of the scalene muscles and the sternocleidomastoid muscles was no longer visible. In addition, the patient's posture was upright and her facial expression relaxed. The painful misalignment in the middle cervical spine at C4 had disappeared after the treatment without any other intervention. The treatment was repeated with all 3 sequences after 2 days and was no longer perceived as painful. It can be assumed that this diaphragm mobilization, which apparently also has an effect on the autonomic nervous system, can be used not only to treat breathing disorders, but also in posture training and in the treatment of spinal deformities. I would like to thank my daughter, Dr. Paula Michaela Heimel, for her willingness to be my demonstration object for this project.